Afternoon, everybody. Nice to see so many people joining. We'll just give people a couple of seconds and then we'll get started. Zoe, twice in one day. Nice to see you again. We've already been on a separate call earlier. So
hi, Sue.
Nice to see you. Okay, so welcome everybody. So nice to see everyone. I'm hoping that you're expecting to be on a sort of a webinar is probably too smart a word for what we want to have this afternoon, but a conversation with primary care colleagues around outpatients and around some of our thinking in CUH around recognising that outpatients is a priority for us here, but we also recognise that many patients are not getting access to the care and treatment in the timely fashion that we would like them to, and we recognise we need to start to think differently about how we might deliver outpatients, and really keen for insights and thoughts from our primary care colleagues. We've been doing similar work, obviously internally within CUH, but importantly with a range of patient groups to get their insights and reflections as well. So look forward to sort of sharing a bit of information with you around our thinking and why we think there's a case for change, and then really welcome some smaller group discussion around whether we're focused on the right things, your insights, your reflections, things that currently work well, we should do more of, and things that really aren't working, and what we might need to consider differently. I'm just going to probably introduce a very small group of us who are sort of representing CUH in this conversation, and then perhaps when we're in the small groups, people could introduce themselves to each other more fully. But clearly, if people are asking questions in the wider group, then if you can say who you are and where you're from within the primary care networks, that would be really helpful from our perspective. One final thing is we've currently, there's quite a number of people who said that they would like to have joined but weren't able to, and they wondered if there was going to be a transcript or a recording after that. So we have set this to recording. If anyone feels very strongly that that's not the right thing to do, can you let us know? Because otherwise we will make that available for our GPs to be able to access through the website. So just so people know in advance. So as I said, welcome. It's really nice to see everyone. My name is Sue Broster. I am a consultant neonatologist at CUH, but also cover the role of Director of Digital Innovation, Transformation and Improvement. And it's sort of with that angle, with the sort of transformation improvement, that I'm sort of holding the brief on what could outpatients transformation really look like and how might we approach that. So really looking forward to the discussion this afternoon, and thank you to everybody for making time. Laura, if I hand over to you.
Hi everyone, I'm Assistant Director of Strategy at CUH, Laura Dunklin.
Jude.
Hi everyone, I'm Jude Simpson, I'm Director of Strategy at CUH.
Rosemary.
Hi, Rosemary Stevenson, Associate Director of Strategy, CUH.
Matthew.
Matthew Zunder, I work in the strategy team, strategy advisor.
And Katie.
Hi everyone, I'm Katie Roberts. I'm the Primary Care Liaison Manager for CUH.
So thank you. So we've got a sort of a few slides to sort of set the scene, and then we'll get into the discussion if we can. Recognise that some colleagues may join over the course of the session, depending on other sort of clinical commitments. So we'll next slide, please, Laura, if that's okay. So thank you. So I mean, I think as I've sort of headlined at the beginning is next slide, Laura, if we may, is that we know that demand is growing for outpatient services, and I think to be very honest, and you'll see from the respective graphs, we are finding it harder and harder to keep up with that demand, despite making really focused attempts on increasing our activity, which we are. And that if we continue to work the way we are with the number of referrals and the needs of the patients who are being seen here, we're going to significantly outstrip the capacity that we have got. So not changing is not an option. We recognise that to meet the needs of our patients, we need to think differently about how we deliver our outpatient services. Next slide, please. It's also compounded by the fact that looking forward, more and more people will be living with multiple long-term conditions and potentially much more complex care requirements. and that within our own system, Cambridgeshire and Peterborough, the population is already growing significantly and projected to grow very significantly over the next sort of 10 years, with our population of over 85 expected to grow by 128% by 2041. Population of under 18s is growing at a slower rate, but it remains a really important population group for us to make sure we access and support their needs, and also the significant inequity even within our region, with gaps in life expectancy across some parts of our population of over 10 years. So lots of reasons why, with the ongoing demands and complexity in the system, we might need to think differently. We know that we've got some technologies within CUH that can help us do some of this, but it may not be sufficient. So we moved to an electronic patient record here in 2014. I know for some primary care colleagues that will still seem quite recent. Many of you have been on using digital technologies for far longer than we have. And we have a reasonable level of maturity in that. So we know that we're using it well. We've just been reaccredited as having a HIMSS level 7, so it's the highest level of digital maturity in terms of the way we use it. So we are using it reasonably well. More we could do, but it's something that we have really embraced and taken forward. We also know that as we're trying to develop our own technologies, our sort of population around us is also becoming increasingly digitally enabled. That does not mean everybody is, but increasingly people are, and we need to therefore refine perhaps what we're doing and the way we approach outpatients to meet their needs in a different way, differently perhaps from how we've done historically. And there are examples in other parts of the country where people have started to think about how they use data to help inform the decisions that they're making. And there's a couple of examples there that I'm very happy to come back to in more detail if it's helpful. So as part of that sort of context, we've been thinking for really quite a lot over the last few months with a wide range of stakeholders around what should and could outpatients look like, and our responsibility for that as a hospital. And I think it was framed around really focusing on making the care personalised, making it seamless and efficient, and thinking differently about the way we work, and then using sort of collective resources to deliver the right care in the right place at the right time for our population, and thinking about how that interaction between ourselves and community and primary care really needs to grow, and how do we do that well. So that's part of the question for today. As part of that, we recognise that that's not necessarily something that we can do all of that immediately. Laura, if we just move to the next slide, if that's okay. So thinking about what we might, some of the sort of more simple things that we might need to, within CUH, think differently about in the next 1 to 2 years. So what more could we do with things like MyChart? How can we improve scheduling? How can we make sure we maximise clinic utilisation? So there are things that are entirely within our gift internally that we really need to focus on and make sure we've maximised all those opportunities. But we do need to then think more broadly about what is a longer term strategy for outpatients, and that's really the sort of prompt for the discussion today. Feeds into the wider discussions that I know are happening sort of with the thinking about what does acute care look like, and also I know within the system there is conversations with the ICS around what does a sort of system change in the longer term, how does that involve, and what are the models of care that might fit within that. But this is very focused on the outpatients arena for the work we're talking through today. If we're thinking about a vision, which is about 5 to 10 years away, so there's a kind of what do we do now? How do we start to shape and build on that on the next 3 to 5 years? And in 10 years, what does a slightly bolder vision of outpatients look like? And we started to scope out some ideas of what that might include. Next slide, please, Laura. And again, that's framed around that same initial vision that we outlined at the beginning: personalised, seamless and efficient care through partnership working. And I've sort of broken that down into 3 bits. So we recognise that we really need to focus on making care much more personalised within CUH, responsive and designed with and for our patients. We think in 10 years' time there will be significant increase in technology that's available to us that will automate some of what we do, and that should free us up to be able to focus on providing care as the caregivers and professionals to our patients. But we need to use data to really help us be intelligent about how we do that. And there is more work to do around our estates and infrastructure and how that's accessible for a proportion of our patients. So we probably need to think differently about outpatients, as we talked about that increasing complexity of patients, that actually maybe care is outpatients is broader than just a single visit to or a series of visits to a hospital. Maybe it's more of an out of hospital care service rather than just an outpatient service, and a range of different functions that could be included in that. And and that really needs to be, I think, as an area we'd really like to explore, is what could and should that look like. And I think, you know, this is very much a sort of early conversation around, you know, what are the things that we could do together. Particularly interested in people's views on that this afternoon in some of the whole group session, and also in some of the small group sessions around, you know, are there opportunities for joint clinics? Are they valuable? Do they add any value or not? Shared MDTs, I know there's a couple of pilots that have been running for some time around neurology. You know, should they be increased? Are they helpful or are they not? Should hospital physicians and clinicians be working and sitting alongside our primary care colleagues? Should we move out of the hospital as is? You know, remote appointments, a whole range of ideas that are on the table, and some of these are already in practice here, some are in practice in other parts of the country. And secondly, really thinking about how we prioritise both primary and secondary prevention, recognising we have different expertise and in some of those different areas, but how do we combine that for the benefit of our population as a whole? And finally, really focused on putting patients right front and centre, which I know something that's really important to all of us, and giving them control of their care, and also the information around their care, and how and what could we do to support that. So we've been doing quite a lot of work, I think, Laura, if you can move to the next slide, that talks about already to some of this, to give us some principles as we really start to think about how we develop this piece of work. I've done a lot of conversation with patient and public, and overall patients are largely positive about the standard of care they receive, but accessibility, and I've heard that in a number of forums, that accessibility is a really big challenge. And I think that comes back to the fact that we therefore have to do something different if we're going to make our outpatients model more accessible and more effective for our patients. But patients are cautiously, and I think that's an important word, open to new models of care, but we need to make sure that we remain in conversation with them. And they've three key things that we've really drawn out of that is poor accessibility emerged as the most cited theme, and I suspect that's also something in primary care that you regularly get highlighted to you, is that waiting time and information about when patients are going to be seen and being on the waiting list. So we know that that's a really important thing we have to address, and so that's a real focus. Differing accessibility needs is another area that we really need to pay attention to. Parking is an issue, and I think that comes back to, is it all about coming on site or can we work differently? And then thinking differently about what kind of opportunities there are with pharmacy to do things differently. And there are conversations already underway to look at how we can perhaps work more closely with pharmacies based much closer to patients' home as opposed to being in the hospital setting. Communication is always key, and we shouldn't underestimate that. And virtual appointments have a place, but it's not always straightforward. Patients have said that you want more options for engaging with the hospital without the burden of managing their care in totality. So we do need to think about what that really means. My chart is well received, but is not always that user friendly. And again, I think some useful insights there. And from the patients and public perspective, they're open to different care models, but it's really important that we work with them. And I think that's central to the conversation also we're having with all of you. And they've got to be tailored to individual preferences as well as clinical need. So we're a much earlier conversation, I think, with primary care. We have had, and I've had conversations with a number of people on a one-to-one basis who are in primary care, but we want to have a much wider and start to accelerate a much wider conversation with colleagues. We know there's some underlying principles that we think are important, but you may disagree, and please do if they're not correct. Whatever we do, we need to co-design in partnership with primary and community care. This is absolutely not about shifting work onto primary care colleagues. It's about saying we have a responsibility for the work we do. How can we do it better and meet the needs of our patients? And it's a really genuine question of all of you, and you will have, I'm sure, many reflections on that. We know outpatients wait impact GPs through repeat attendances and requests for support. And again, how do we mitigate against some of that while we're trying to move to a different model? And we also know that, and a reflection from many of you, is that you manage huge complexity, and perhaps you've got real insights there on how we can, within CUH, understand patients more holistically, and some of your insights in how we approach that would be very valuable. So really, we've really got 2 questions. Very happy to take some broader conversation in the whole group, but specifically it's sometimes more helpful to really get into the detail of some of that, and particularly these 2 questions in smaller groups. How can CUH and general practice work together to improve outpatients care for patients? What do you think that needs to look like? As I say, some of your insights, and how do we therefore deliver that care to the patient in the right place at the right time? And how can CUH help you support patients who need outpatient care? So that comes back to the last bit, that we know that has an impact on you already. Accessibility is a challenge. What are the things that might be helpful from our perspective that we could do differently that might improve that? So imagining what care could look like in 10 years' time, how do we get there? What are some of the hurdles on the way? How could we do it better? And what are your insights in how we can shape that? I hope that's just a very quick run through, because actually the most useful bit will be the conversation rather than me talking to you. We'll make sure you've got this information available to you. But any immediate reflections will be welcome. Otherwise, I think we'll probably move us into smaller groups. But if there's any immediate reflections, I'd be very happy to take them. Zoe, can I put you on the spot? Because I know you, and I can see you on my screen. So we had a similar conversation, didn't we, last week? And when we met as a group of CUH and primary care colleagues around some of the challenges, particularly around accessibility for patients, and our responsibility to work really collaboratively with primary care. And I'm really very interested in how we can do that well. So any reflections that you've got on that would be very welcome.
I had a really interesting chat with Claire Stoneham as well after the GP consultant meeting, and just really thinking about how far can we push this vision, how innovative can we be. And quite often I'm with a patient and I think they don't need to go all the way to Addenbrooke's, but I could really just do with a little bit of help right here, right now. And I think the neurology clinics that you touched on, where you have that immediate access to a specialist, can be just so helpful. We've had a heart failure clinic running in Ely, but unfortunately the funding is running out, so it's going to be ending. But just upskilling us all and knowing what our strengths are, really understanding our differences as well, can just be so helpful. I have a husband and a daughter with a chronic condition, and I would really rather never go to the big shiny hospital for an outpatient hospital appointment. So yeah, I hope we can have some really good discussions, really. And thanks for setting the scene, Sue.
Thank you, Zoe. Simon.
Yeah, thank you. For those who don't know me, I'm senior partner at Fenland Group Practice in Fenland, funnily enough, but I also sit on the ICB board. And for me, there's some kind of real fundamental questions to answer about this, which is, why do I sit in my consulting room and refer a patient to a hospital? What am I trying to get for A, my patient, B, for me as a doctor? And how do we then meet those needs? So I might have a professional curiosity or professional question, or need to access a service which is only provided in hospital, which is the right thing, obviously. We can't all have MRI scanners in our GP surgeries, even if we might quite like them. And then clearly, obviously, what do the patients need out of that transaction too? And same, as Zoe sort of alluded to there, there are things where we might have questions, we need a bit of help, but and for my patients, a trip to Addenbrooke's Hospital in particular is a day trip. That's something which takes all day. By the time they've had their hospital transport from Fenland, it takes about 4 hours to get there, 4 hours to get back, and maybe for a 10-minute consultation. So there is there about efficiency. I also think there's some wider questions there about accessing for primary care for investigations. And I was talking earlier on, we obviously have our practice closure afternoon this afternoon. We're spending some time with all our staff on making every encounter count. And some of the things that I was talking to there was about, really maximizing the impact of everything we do and making sure everything gets done properly. So, and we're talking about some of the things that might be automated. So, common scenarios, things that we see in general practice, men presenting wanting PSA testing, we get these equivocal raised PSAs. We have a system at the moment whereby we're doing 2-week wait referrals into cancer services in order for a consultant to write out a request for an MRI scan. Well, why can't we just say this man's PSA is this and this? Can you do an MRI scan, please? The scan then goes to an MDT, and then you see the patients who need to be seen by the consultant urologist. There'll be another group of patients who need some information about ongoing monitoring, and another group of patients who just need a letter back saying, it's all right, mate, you're absolutely fine. You've got nothing to worry about. And we don't do that sort of thing very well at all, because we have very fixed type of protocols which are imposed upon us. I think there's huge benefits there to be had for remote consulting for people with long-term conditions, diabetes, heart failure, hypertension, etc. So some of these patients are causing us huge amounts of work in primary care, and we just need that bit of input. And there are some really great models there where the patient and the GP can sit in a room, or even the patient and the nurse can sit in the room, and a consultant's on the other end of a video link, giving some advice. One thing, obviously, we are particularly poor at in the UK is sharing information, because unfortunately we have 2 major hospitals in our system that have no electronic patient records. We have one major hospital that has a completely outdated electronic patient record, and we have got one hospital that's got a half decent one. But it's still not terribly good at talking to GP systems. And because GP systems themselves are horribly outdated and clunky, and should have been consigned to the scrap heap many years ago. But it is what it is. So I think we can look at innovative ways of doing it. And I think in the current climate, obviously, primary care is really, really struggling. There are some real severe threats on the horizon for us around funding. And it's creating a really difficult environment with the primary secondary care interface. But where secondary care can really help us and we can help it, then we can all work together. And I think we could have a better future together than one which is sadly, I think, currently at loggerheads with each other, which is why I wanted to join this meeting today to see if I could make contribute something positive to it. I know it's a very, very difficult kind of situation at the moment because there is no money, and we're all painfully aware of that. So the first thing we have to try and do is stop wasting it. And I just said that a lot of the letters I get back from hospitals indicate a waste of time and a waste of effort, because the patient didn't need to go in the first place, or it could have been done in a better way. But on that, I'll shut up and sort of contribute in the smaller groups.
No, brilliant, and thank you, Zoe and Simon. Actually, I think two really important things that took away from that, which is really good framing for the sort of next part of the conversation, is how bold can we be, and let's make every encounter count, and let's try and think about how we can do that collectively together. So I think two really helpful sort of framing as we go into small group. Laura, remind me, how long have we got in the small groups? About half an hour.
Yeah, I think up to half an hour.
And then what we'll do is we'll ask someone, whoever wants to be nominated as somebody, to come back and to speak to the wider group around any insights and feedback to share, which would be great. So when people get into small groups, we can help coordinate that. So Laura and Matthew, I'm not sure who's going to put us in, and hopefully in a minute we should all appropriately find ourselves with a smaller group of people and look forward to the discussions. So nice to see everyone back. I think we just thought I think it is helpful to share some of the commentary and insights and discussions from the different groups before we sort of wrap up. Laura, I'll hand over to you to wrap up and think about what our next steps are. So perhaps if I start in our group, Rosemary, with you, and then we'll go around the other groups. You'll know who was the nominated speaker. If you could just let me know, and then we'll draw that to a summary and a close and think about next steps. So Rosemary, over to you.
Brilliant, thank you. I'll try, there's a lot of conversation, so I'll try and sort of keep this as succinct as possible. A lot of it came up around the sort of, not just sort of empowering the patient in this, but really it's talk about valuing their time, not just from a time perspective, but also what's lost in terms of cost of travel, wider sort of arrangements, work, etc., that might be lost through all of this as well. And actually the sort of things that we can put in place in terms of valuing the patient from that perspective as well. So for example, if appointments are getting missed, if they're all unable to attend, sorry, I should rather say, having to go back to the bottom of the list, for example, in that, so how sort of that sort of can getting lost in the system and sort of issues of follow-ups there. Also talked about the idea of how we sort of empowering patients in terms of like a one-stop shop, which was sort of a really nice idea that sort of come to in terms of getting diagnostics done. But also it could be coordinated the way that sort of consultants or virtual follow-ups and sort of hubs can be sort of managed in that place as well, particularly if we're talking about sort of digital inequalities and so forth like that as well. Talked about the sort of disjointment in care and the sort of the value lost in having those sort of soft contact points, and how now sort of as an ICS, how we can really be sort of begin to sort of work in that sort of system approach as well. And that sort of value in having that sort of generalist clinician as well. That's sort of a point where perhaps you're needing that sort of end of sort of specialist care, but need that sort of generalist sort of advice and guidance, or needing that sort of particular sort of diagnostic kit or prescription, what have you. So it kind of falls within a spectrum across from that as well. We also talked about work that potentially could be done in just sort of auditing outpatients appointments that perhaps didn't add value, because then we're talking about sort of time and capacity within the system. So basically just sort of making sure that we're sort of using what we have to that sort of maximum benefit from there as well. And again, we're sort of talking about that in a sort of entire pathway discussion as well. So again, the value in having perhaps somebody who can sort of coordinate, particularly when someone's working across multiple specialties, multiple consultants, the value in having sort of one person in sort of coordinating those appointments and scheduling, again, sort of from a patient and sort of follow-up perspective. And then obviously talked about the sort of move to PIFU as well, and the sort of, again, the sort of value in that, because we talk about if people are just sort of returning for appointments due to a sort of arbitrary, should we say, set period of time, again, that sort of valuing the sort of clinical time from that. So again, the sort of use of PIFU in sort of maximising time and space from that. I'll pause there in case anyone else wants to add anything from our discussion.
Thanks, Rosemary. I think that was a good comprehensive summary. Conscious of time so that we finish at 5 for everybody. And I noticed I've got a system goal call, which tells you it's already bad in the acutes at 5. So which is just pinged into my diary. So I'm going to make sure we finish on 5 for everybody. Who else was a nominated spokesperson? Go for it, Zoe.
So we just decided that Addenbrooke should give general practice more money. No, we didn't really. They said I could be spokesperson, so I said I would just play it to my agenda then. So we had a great chat about just the challenges in general practice at the moment. Appreciating the fact that we're in collective action at the moment, and financial pressures in general practice are really tricky. So anything that's moving any work to general practice, need to be really careful about that. It needs to be done in a really good way. And there is so much capacity within general practice to be really innovative in this space, but we are really hammered at the moment with lots of many different constraints. We had a chat about how the radar service at Addenbrooke's works really well, and moving towards that kind of model for other specialties. John said that there would be appetite from some people to do more of that work if it was planned. So you call up, you get a phone call back when the consultant can speak to you, and you just have a really great chat with the consultant. It's just so useful to have more conversations. Talked a bit about advice and guidance and how to make that a bit more conversational rather than just a one-way shouting into the ether, getting a list of jobs to do, which doesn't necessarily help ease any of the pressures on general practice. We talked about using the smaller hospitals around, so Saffron Walden Hospital, We've got the CDC and Ely and Wisbech now for investigations. Yeah, just being very mindful of the fragile nature of general practice at the moment, and there is so much opportunity for collaboration and innovation, but it's just got to be really well thought out and funded as well.
Thank you.
Thank you.
Any other groups that we haven't, other spokespeople? So just we divide into two groups. Okay.
We did, yeah.
Brilliant. Thank you. Any other final comments that people feel that they haven't covered that they wanted to add? I think two good summaries from Zoe and Rosemary there. Thank you. So Laura, if I hand over to you in that last few minutes.
Yeah, thanks, Sue. And thanks everyone for taking the time to come today. I know how busy you are and how much else is going on. We're really keen to keep engaging and engage in more detail. Happy to have one-to-one conversations with any of you again. I'll put my email in the chat. Equally, if there are kind of groups that you're in that you think we should come and talk to, we'd love to hear about them. We're really keen to get out there as much as possible. So just, yeah, anywhere we can keep engaging, let us know. We'll find other places to come to, and you might see us again at something. But yeah, get in touch if you want to do anything more bespoke.
So thank you. Just to echo that, really appreciate everybody making the time this afternoon. So some really helpful insights there to sort of build on the work. But we'll very much keep in contact with you and come back round, as Laura says, with a sort of further iteration and conversation, and ongoing conversation with us is extremely welcome. So we'd really like to keep that sort of on a recognising, Zoe, as you've said, the pressures that primary care is facing, and also the collective action, so the other demands that you have, how to use your expertise and wiseness as most appropriately as we can as we start to scope this piece of work. Zoe, come in.
Have we got like 2 minutes left then?
Yeah, you've got 2 minutes left.
Well, it would just be really nice to hear Alice's take on this from our LMC, and also Gary as our innovation guy. It'd be great to hear Gary's take on this as well. Just if that's possible, if we've got 2 more minutes.
Yeah, absolutely. So who wants to go first? Gary, should I go? I've seen your front and centre on my screen, so why don't you go first?
Okay, we'll finish on a high with Alice then. I wasn't shy, Zoe, in our group, so a lot of what I've said, Rosemary's already fed back. I think it's absolutely key that we hold the lens of what does this mean for the people that are in receipt of our services, and make sure that they don't fall through any gaps. I think the ambition for the scale of PIFU for anything other than first outpatient should be 100%, because I think that's a way to give maximum flexibility to the capacity we've got, and to empower patients to book that in, and to use some of the tools that patients use to communicate into general practice to be used to communicate into secondary care. And 2, 3, 4 years down the line, I'm sure the AI will be able to help process that. So the worry that they'll be inundated probably won't go. And I think all of the enablers we have around the system, be that digital, CDCs, estates, different workforce, we could use to mean that physical proximity to patient and consultant in the hospital estate isn't necessarily the starting point of the solution that we dream up. Over to you, Alice.
I think, yeah, just a couple of points really. I think that point there that Gary was making about sort of the different strategies, the different enablers, the different things that are happening. There's all sorts of conversations that come back to general practice and to primary care about their kind of input and feeding into these types of conversations and things, and they're often in isolation, and it would make it'd be great if we could draw some of those connections and links to the different strategies, different models of care, different ambitions, so that it makes sense to, you know, we look at it and hear it from the GPs that are quite engaged, but we're also really conscious that there's a GP workforce out there that have just got their head down and are kind of working really hard to navigate all this and don't understand it in that context of the bigger strategy and the bigger picture, because they just haven't got time to lift their heads for that. So anything that we can do to kind of pull that message together, distill that message and bring that engagement through will really help. Another thing is when the engagement is sought is around actually seeing then some of that input reflected in then some of the documentation that comes out, or some of the changes, or some of the wording of things, because there's often a lot of conversations, a lot of discussions that happen, and then you see something later on that comes and think, well, God, none of what we said kind of made it into it. So I think that would be really really important to see. And the bit that we sort of picked up in the group that I was in just now was the piece around the pathway, and some of the pressure and tension at the interface is because it feels like it's been forgotten that the stuff that sits out of the hospital that isn't currently in a clearly commissioned pathway has got a cost, has got a time, has got a burden around it there, so that and it isn't just there to be picked up by capacity that doesn't currently exist out in general practice. But I think all of these conversations are really helpful. It's that it's our job in terms of the people that are kind of pulling this sort of stuff together to try to ensure that we get it in a way that other people can understand and see it in the bigger context of the other strategies and other working groups that are happening. But yeah, sorry, I'll stop there.
No, thank you, Gary and Alice. Some really nice sort of broader reflections, I think, to sort of just bring together the conversation towards the end of the session. Any other final comments that anyone would like to make, or reflections? I see there's a little bit of sort of suggestions and ideas in the chat, so that's very welcome. So thank you very much for that, and we will definitely follow up on some of those other conversations. But otherwise, thank you very much for all your time. Absolute pleasure to kind of have that conversation today. So I really appreciate that. And have a good rest of the evening. Thank you.
Thanks. Nice to see you, meet some of you. Take care. Bye. Bye.